Welcome. The topic we are now going to talk about is cancer-associated thrombosis, emerging evidence, and practice guidelines. In the United States, 1.8 million new cancer cases were diagnosed in 2018. 14 million cancer survivors exist in the United States. 20% of all will develop cancer-associated thrombosis. CAT has a six-fold increased risk of VTE, which is highest following surgery, initiation of chemotherapy, and with the development of metastases. CAT risk is site-specific, being highest with cancers of the brain, pancreas, digestive system, and with hematological malignancies. CAT risk is also stage-specific, being highest with advanced cancers than with the initial stages of cancer. CAT risk is also known to be duration-specific, exhibiting an odds ratio of 53.5 within the first 3 months of diagnosis of cancer, 14.3 within the first year, and less than 5 within the next 15 years in those who survive. CAT recurrence is known to be highest in the first month after the index venous thromboembolic event. CAT risk is well known to be chemotherapeutic agent specific, being highest with tamoxifen, thalidomide, lenalidomide, cisplatin, L-asparaginase, 5-fluorouracil, bevacizumab, gemtuzumab, recombinant erythropoietin, and leukocyte growth factors. CAT, of course, adversely affects survival, with higher mortality noted in the group of combined venous thromboembolism and malignant disease when compared with those with malignant disease only, venous thromboembolism only, and non-malignant disease. Anticoagulants are the mainstay of cancer-associated thrombosis therapy. An ideal anticoagulant must be convenient for oral administration, has a wide therapeutic window, has a low risk of food and drug interactions, has safe and effective regulation of coagulation from the first dose and throughout therapy, exhibiting a predictable response, no need for routine laboratory monitoring, and with a fixed dose for the majority of patients with no need for dose adjustment. Traditional anticoagulants have certain drawbacks that could impact patient compliance to the administration of anticoagulants. Unfractionated heparin is given by the parenteral route, needs monitoring and dose adjustment, and bears a risk of heparin-induced thrombocytopenia. Low molecular weight heparin is given by the parenteral route also and is given by a dose adjusted according to weight. Oral vitamin K antagonists have a narrow therapeutic window, interact with food and drugs, and need frequent monitoring and dose adjustment. The Duke University performed an anticoagulant satisfaction survey in order to test the compliance and convenience of oral versus subcutaneous route of administration. Only 4% receiving oral apixaban discontinued the drug prematurely, whereas 15% of patients receiving subcutaneous dalteparin discontinued their drug prematurely. This difference was highly statistically significant. As shown in this figure, there are two categories of direct oral anticoagulants. Those which are direct activated factor 10 inhibitors include apixaban, rivaroxaban, edoxaban, and betrixaban, whereas direct thrombin inhibitors include the prototype dabigatran. Evidence regarding the use of anticoagulation in the setting of cancer-associated thrombosis evolved over three phases. Phase 1 compared to prophylactic anticoagulation with placebo in the PROTECT and SAVE-ONCO trials. Phase 2 compared low molecular weight heparin with warfarin in the CLOT trial. And Phase 3 compared direct oral anticoagulants with low molecular weight heparin in the ADAM, Caravaggio, and SELECT-D trial. The PROTECT trial was a placebo-controlled, double-blind, multi-center clinical outcome-based study. It evaluated the efficacy of nadroparin for prophylaxis of CAT patients receiving chemotherapy. Treatment was started on the day of initiation of chemotherapy. The primary endpoint was clinically overt venous or arterial thromboembolic events. Major bleeding was the main safety outcome measure. The study concluded that nadroparin did protect against CAT with a non-significant bleeding risk compared with placebo. The SAVE-ONCO trial was a double-blind, multi-center trial. It evaluated the efficacy and safety of the ultra-low molecular weight heparin, cimeloparin, for the prevention of CAT in patients receiving chemotherapy. Subcutaneous cimeloparin, 20 mg once daily, or placebo was administered. The primary efficacy outcome was CAT or CAT-related death. Clinically relevant bleeding, both major and non-major, was the main safety outcome. The study concluded that cimeloparin reduced CAT with no apparent increase in major bleeding compared with placebo. The CLOT trial was the second phase of evolution of studies and evidence regarding the use of anticoagulants in the setting of cancer-associated thrombosis. In the CLOT trial, patients with acute symptomatic proximal CAT were randomly assigned to receive either dalteparin, then a coumarin derivative for 6 months, or dalteparin alone for 6 months. The CLOT trial concluded that dalteparin was more effective than coumarin in reducing the risk of recurrent CAT without increasing the risk of bleeding. The third wave of evidence evolution regarding the use of anticoagulants in the setting of cancer-associated thrombosis was the ADAM, Caravaggio, and SELECT-D trials. In the ADAM and Caravaggio trials, which were multinational, open-label, randomized, non-inferiority studies, apixaban was compared with dalteparin in cancer-associated thrombosis for 6 months. 1,155 patients were involved, and the primary endpoint was major bleeding for the ADAM trial and CAT recurrence within 6 months for the Caravaggio trial. They concluded that apixaban is non-inferior to dalteparin in CAT recurrence prevention, no increased risk of major bleeding, with a relatively higher clinically relevant non-major bleeding with apixaban. The SELECT-D trial was a multi-center, randomized, open-label pilot trial in the United Kingdom. CAT patients were allocated either to dalteparin or rivaroxaban. The primary outcome was VTE recurrence over 6 months, and safety was assessed by major bleeding and clinically relevant non-major bleeding. 400 patients were involved, 58% of whom had metastases. The SELECT-D trial concluded that rivaroxaban was associated with a relatively low CAT recurrence within 6 months, but a higher risk of clinically relevant non-major bleeding compared with dalteparin. Cancer-associated thrombosis guideline development around the globe is now led by three big bodies: the American Society of Clinical Oncology, the National Comprehensive Cancer Network, and the European Society for Medical Oncology. For acute CAT, two bodies elaborated guidelines regarding acute cancer-associated thrombosis. The American Society of Medical Oncology recommended low molecular weight heparin followed by edoxaban or rivaroxaban. The National Comprehensive Cancer Network recommended direct oral anticoagulants, apixaban, edoxaban, or rivaroxaban, preferring them for non-gastric or non-gastroesophageal cancers, and recommended low molecular weight heparins for gastric and gastroesophageal cancers, or dabigatran if the above regimens are not appropriate or not available. Regarding the issue of prophylaxis in cancer patients who haven't yet developed a thrombotic event, the three guideline developers recommended against routine venous thromboembolism prophylaxis, except in certain conditions. The ASCO restricted prophylaxis to high-risk patients with cancer to begin with low molecular weight heparin, apixaban, or rivaroxaban, in addition to myeloma on thalidomide or lenalidomide to be given aspirin or low molecular weight heparin. The National Comprehensive Cancer Network restricted prophylaxis to intermediate to high-risk patients with a Khorana score of 2 or higher, with apixaban or rivaroxaban, and even low-risk patients with myeloma on imides with aspirin, and high-risk patients with myeloma on imide with apixaban, low molecular weight heparin, or even warfarin. The European Society for Medical Oncology was somewhat conservative about this issue, and the only exception was very high risk solid tumors or myeloma on thalidomide or lenalidomide. In order to have justification for CAT prophylaxis, we have to calculate the Khorana CAT risk score. This is a score based on the cancer type, pre-chemotherapy platelet count, hemoglobin level, pre-chemotherapy leukocytic count, and body mass index. These data are entered into a special software that can be obtained from Google Play or the App Store, and it is able to calculate the risk score. If the score is 0, then we have a low risk of venous thromboembolism development. If the score is 1 to 2, we have an intermediate risk. And if the score is 3 or higher, we have a high risk of developing a venous thromboembolism and cancer-associated thrombosis. The VTE risk with low-risk cases is 0.3 to 0.8%, with intermediate risk patients 1.8 to 2%, and with high-risk patients 6.7 to 7.1%. Thus, we will have an evidence-based approach to cancer-associated thrombosis prophylaxis and resolve the debate about this issue. Thank you for your attention.